our next slide, we are going to talk about client safety. And one of the things we're going to talk about with safety, we're going to start off with falls. In your book on page 66, you'll see those different things about falls and how to prevent it as a nurse. So, what are those contributing factors of falls? Anyone? Correct. Age. Age is a factor, impaired mobility, and medications. Now let's talk about age for a moment tomorrow. When we say age, who are those individuals, the aging person, at risk for fall? At what age would we say? Correct. 65 and older. You're older adults, right? Because that's what we say all the time. Who next? Carrie? Toddler, infant, absolutely. They are at risk for fall, absolutely. Next is impaired mobility. What are those things that could make a person have impaired mobility? IV, exactly. That's correct, Christina. Any kind of IV, transfusion, anything hooked up to the client could cause them to fall. What else could impair their ability? Intubation, absolutely. We talked about IV already. Very good, Carrie. What else? Okay, so there's any time a patient in the hospital, they are at risk for fall if they have surgery, correct, right? Especially bone surgery, they are at risk for fall. Very good. Next, we're going to talk about medications. Now tell me, what are the common medications would increase a client risk for fall? Opiates, absolutely. Good job, Carrie. Opiates, what else? Diuretic, absolutely. Diuretic, because they always have to use the bathroom, so they're at risk for fall. Also, a lot of the diuretic could cause a decrease in potassium level, making muscle weakness, so they are at risk for fall. What else? Absolutely. Yes, you are correct. Anything that sedate them, benzodiazepine, with the NCLEX, any kind of antipsychotic med could make a client at risk for fall. Just keep that in mind, okay? All right. So next, we want to talk about our fall risk assessment. Now, when your patient come in, we want to make sure we do what? Assess them for fall. You said the brain fall risk. Absolutely. Good job. Very good. We want to make sure we assess them for fall risk. The next thing we want to make sure, as a nurse, we want to intervene. And what do we want to make sure happen? A safe environment. So what are some intervention we can do to make sure that the patient is safe? The lights, absolutely. Give them light. Not a lot of bright light, but some dim light, night light. What else can we do? Carrie, you're so good. Call bell within reach, absolutely. And what did you say, Tamara? Make sure the bed is low, absolutely. Very, very, very good. And Tanya, you were trying to say something. What did you say? Make sure there's no clutter. You guys are so on the ball. Very, very good. And I didn't hear, make sure the client come close to the nurse's station. Oh, and Carrie said, make sure they have a non-skid socks. Make sure they have those socks that can prevent them from falling. Absolutely, you guys are so good. I love it. We're going in the right direction. Very good. So here's a question we're going to talk about. A nurse documents clients placed in restraints after wandering and refusing to return to bed. Which conclusion should be made about the documentation? Number one, it is an objective account of this client's potentially harmful behavior. It provides insufficient evidence to support the need to restrain the client. It legally requires the signature of 2 nurses support use of restraint. It needs to describe attempt to resolve the insomnia before using a restraint. I have a lot of people say number 2. Anybody else? Good job, guys. Let's see. It provides insufficient evidence to support the need to the client. Now, I know we talk about the stop approach, right? But let's talk about this. Restraint. What do we know about restraint? You need a doctor's order. Can you apply a restraint before you get an order? Yes, you can, but within 1 hour, you got to make sure you get a doctor's order. Very, very good. How soon should the doctor Make sure to check the patient to see if there's still a need for restraint. 24 hours, absolutely, Christina, you know your stuff, for 24 hours. Now, when a patient is on restraint, how often should we release it? Oh my, every 2 hours, Christina, absolutely. And in that 2 hours, when we check what? Circulation, pulse, right? Very, very good. See if the skin, the area is very well. You guys are doing so well. Now, remember, one thing I want you to know about restraint, and with the NCLEX, you want to try the least restrictive, correct? Make sure that that's the last resort, and the only time we should use a restraint if it's going to affect the patient safety of his care. If he's trying to pull out his tube, we restrain them, or the patient is at injury to self or others, correct? And keep in mind, if we need somebody to watch our patient, we got to keep in mind it should be somebody work in the hospital that's taking care of the client, not a family member, correct? All right. The next question, the nurse considers the use of a wrist restraint to a client with peripheral IV. Which findings should be evaluated before applying a restraint? Should it be the time required to restart the IV if site is compromised, the current staffing level of the nursing unit, the presence of family members at the bedside, and the reason the client may potentially pull out the IV? What do we have? Give me a number. Use your cards. Jordan said number 4. Carrie, number 4. Who else? Number 4? Oh, everybody said number 4. Let's see what the answer is. Absolutely. You want to make sure you know the reason the client may potentially pull out the IV. We cannot just put a restraint just because. The presence of a family member at the bedside? Absolutely not. We cannot trust the family member to be there all the time. It's our duty to care for the client. The time required to restart the IV site? Absolutely not. Staffing level? Absolutely not. So the best answer is number 4. Very good, guys. We on the ball. Now let's talk about seizures. Now, on page 66 to page 67, we're going to talk about seizure, right? Now let's talk about pre-seizure first. When you know somebody at risk for having seizure, what do you do before it happens? Okay, good job. So here what Christina here is taking precaution. She's saying, make sure the bed rail is padded, because we know they have it. But what if your patient is standing? What you going to do? Make sure they lay down. Some patients start with an aura. They could know that they're going to have it. So make sure they're laying down, correct? Now that you know that they're at risk for seizure, you're doing those preventative measures. So now the seizure is going on. What do you do during the seizure? Carrie said you want to make sure you protect the head. Absolutely. What else do you want to do? There we go. Do not restrain them. Oh my goodness, you guys know your stuff. What you say tomorrow? Absolutely. Do not put anything in their mouth. Do not put anything in their mouth. Absolutely. What else can we do? Give me one more. Make sure their clothes is non-restrictive. You guys know your stuff. Good job. Very, very good. So you want to protect the area around them, protect them, correct? Make sure that they are not, all right, restrictive. Now, post-seizure, we want to make sure we do what? This is where we recover the patient, and we want to make sure we turn them on their side. That's what Tanya said. Make sure they turn them, because what's going to happen most likely? They may vomit, and you do not want them to aspirate. So you want to make sure you know the time when they first start the seizure. That's a main important thing. And you want to make sure you keep them safe, do a set of vital signs, make sure you're recovering the patient. Correct. Now, environmental safety, we have ergonomics and positioning. Ergonomics, we want to make sure we, as healthcare providers, are safe. We want to make sure we use lift when we lift to our patient. We're not going to harm ourselves. We want to make sure we put the bed. How far we want to put the bed? at waist level. Make sure we don't bend our backs, right? Do we use our strength to lift patient, or will we use a device? Absolutely. Per the NCLEX, mechanical assistive device is what is preferred instead of using your own body. Very good. Good job. Now we talk about race. Everybody should know race. What is race? What is the R? We want to rescue. You want to protect the client. Correct? Move them from that area. And you want to pick those clients that are more able to ambulate. As much client who can move by themselves, get them out of there. The A is for alarm. You want to press the alarm. You need to alert a full team to help you. So you want to make them aware. Now C, you want to confine. You want to make sure you keep confine the fire in one spot. Because make sure if the doors are open, then oxygen is going to build and cause the fire to go more, so you're confined. And then E, you want to extinguish. All right, use appropriate extinguisher. Our next one more question. A nurse cares for a client who is receiving chemotherapy. Which action should be implemented in the IV if the IV separates? You want to notify the housekeeping to clean the spill solution. You want to complete an incident report about the spill of chemotherapy. Use a towel to clean the solution and dispose of the biohazardous bag. Or you want to use a chemotherapy spill kit. Oh, a lot of 4. Very good. You want to obtain a chemotherapy spill kit and use according to direction. Housekeeping is not going to, you cannot have them dispose of it. Incident report about the spill, you could do that after. But now the question is asking you what you're going to implement should it be separated. Correct? Very good, guys. You guys do a good job.